Dr. Claytor here.
David Sena.
And I'm Pedro Piccinini.
We're down here at the MARC Center in Miami, which is a phenomenal resource center for doing cadaver dissections. We're down here demonstrating the latest and greatest techniques, but we're here to debate and talk about some different things. And so I want to hear from these two experts, facelift experts. How do you manage the submandibular gland? What do you do? How do you address it? How do you evaluate them ahead of time? What do you talk to them about? And then how do you address it surgically?
Well, in my case, I used to use 3 steps for evaluation and diagnostic and see which kind of technique you're going to perform in this case. The first part is to see how the patient stays when we put the chin a little bit lower.
And they flex
and
their
see,
neck.
Yeah, and flex the neck and see how bold movement comes here, and see after that ask to do over the chin again to see if it has any kind of shadow here, and see if I need to treat the gland or not. The second move is going to use the ultrasound diagnostic to see if you can measure the platysma and the surface of the difference between the mandibular zone. And the third move is during the dissection of the surgery specifically. I'm gonna look at that and see if it's possible or not.
How about you, Pedro?
Yeah, I have a very similar approach. I also ask the patient to look down. We take this picture and see how this bulges the submandibular glands, and then we discuss with the patient how much of a bother that is to them. We can often get a reduction in the gland size through here, or putting some stitches to really tuck the muscle up and tuck the gland in and give a really nice neckline and jawline.
My number one go-to is I do this. I just palpate it. I just get right in there, and then I have the patients palpate themselves, and they self-validate. They're like, "Oh my God,
I have it.
What is this?"
Yeah.
And then I'll have one of my nurses who has a beautifully carved, sharp jawline come over, and I'll say, "See this jawline? Feel," and they'll, the nurses are all nice. They're like, "Oh, I don't feel any glands on that person." And they're like, "How come she doesn't have any glands and I do?" I said, "Well, as we age, you have, just like everything else is loosening and falling down, you lose those ligamentous attachments that are holding that gland up there, and it prolapses down." Do you think that the glands grow in size as patients are aging, or that they just are prolapsing?
I think there's 2 parts of the same situation. They grows and they goes down.
So you really think it's getting larger?
Yeah, I think they generally come down. I think some of the studies show that but again, it's controversial, right? A lot of us discuss this, and there's not really a good
because you see the same about the parotid. You can see when open it's really huge, but I believe that's the same the submandibular gland.
So, all right, so that's how you evaluate it, and then intraoperatively, you're confirming that, or making the determination, "Oh, we don't need to take them because they're not that big." But all right, let's say you get in there and we make the determination that confirms with the physical exam ahead of time and the ultrasound that these are impinging on this neckline. How do you treat it?
Well, I believe that does not the same rule for all situations. We did the diagnosis before the surgery, but when I see by my eyes, with my eyes, I can see if it really need or not. The great goal here is to make the angle sharp. So I'm gonna do whatever I need to do to make it sharp.
But how do you physically take out the glands? Do you do it anteriorly, laterally,
I do
artery?
medially.
What do you do?
I do a medial approach like here, and see by the side of the gland, and see how it works. If the relationship between the middle part and the lateral part, and the relationship with the platysma specifically.
Okay. How about you?
Yeah, I do the same thing. Anterior approach makes an incision in the neck here, which gets pretty well hidden, and then we can treat all these deep structures in the neck, take the gland out. I inject a little bit of Botox and then close over the gland to really stick it up.
So I do the same, make that incision underneath the chin. And these muscles right here, these are called the platysma muscles. And so we'll take out whatever fat's there, and I'll lift, so from this side, I'll lift up that platysma muscle, and then I'm looking down in this hole. And it's, it's the opening's this big, and so we have headlights that allow us to go down there, magnification. So you go down there, and This muscle right here is the anterior digastric muscle, and it goes down to the hyoid bone, and then there's a posterior digastric muscle that goes back up this way, and those create basically the anterior and inferior border of where the submandibular gland is. And so share with everyone, what are some of the concerns and frustrations, and honestly, the reasons that not every surgeon feels comfortable taking out the glands is because of the arteries that are in there.
Yeah, the arteries, and we're really afraid about the nerve damage.
Yeah. Well, we're not afraid, we just pay really close attention.
Yeah, actually we take care about the arteries, about the nerves, and about the swelling as well.
Yeah.
Because when you make a deeper approach, you're going to see different stages of the anatomy. It's why it's so interesting, so important to make kind of studies like we're doing now.
For sure. We're doing a lot of anatomic dissections, which are really just reinforcing the anatomy that we already are very comfortable with, but now we're making maps to educate others. But the artery that you were talking about is a branch off of the facial artery. And the facial artery, not everybody can feel it, but it kind of is right about here. Would you say that's about right?
Yeah.
It kind of wraps around in front of the mandible and then goes up and feeds the face. But there's a branch that comes off to the submandibular gland, and there are some very, very famous plastic surgeons who have advocated against taking the gland because this is such an anatomically challenging area, and if you get into some really significant bleeding there, it can be difficult to address. And I know that all of us do resect the glands, and so we have great respect for these anatomic arteries that are feeding into it. Was there ever a time where you felt that the risk was beyond the reward, and you said, I'm just not going to dissect any further because maybe the anatomy is unusual, and you said, I'm going to leave some of that gland rather than and really go after it?
Well, every time that I see, it doesn't really related to the gland specifically, but well, if I'm going to approach the deep face as well, and I see there's so much, anatomy is not so clear for me, because of fillers or maybe biostimulators or makeup of cover stitch, and I see that's not there. The security of the surgery is damaged. I prefer not to go for.
How about you, Pedro?
Yeah, sometimes I've seen where the facial artery comes into the capsule of the gland.
Yeah.
And so I've taken out less than I wanted to.
Yeah.
And then just try to close the capsule a little bit better to tuck it in instead of taking out as much as I take out on the other side.
I think that the important part is that we're all very knowledgeable surgeons, but we're very safe surgeons.
Yeah.
And we'll assess a situation and recognize, okay, maybe I could take out an extra 5% of that gland, but doing so may just put me at that little bit more pushing up against the anatomy of that aberrant vessel, because these vessels do not run in the same direction and orientation all the time. There are textbooks filled with thousands of variations, and so every single time we're doing this, we're doing it for the first time. And so it's the technique and skill that allow us to have those judgment calls, and those judgment calls are primarily safety, while at the same time trying to achieve that optimal aesthetic result. So let's say there's a little bit of the gland that you feel that you couldn't get out because of a tortuous blood vessel that was wrapping around the gland. How will you contain that gland and try and make it less noticeable so that you can create that beautiful jawline?
Well, say if I have ptosis with the gland, and say if I want to take it off, or not allowed to take whatever I want, I'm going to make the stitches.
Okay.
You can do it. It's very efficient as well. If I'm able to anchor in some strategic situations, strategic place like the mastoid and the hyoid, it's going to be easier to pull it up and then to take it off.
Yeah.
I think it's a great maneuver.
Yeah, I agree. The exact same thing Dr. Sena is saying is, there's different areas that are tighter and that are very solid for us to put some stitches through, both in the front of the neck here and back here. So we can make like a hammock where we pull this sling and tighten this up, And sometimes that's very effective also to hold the gland
Yeah.
and not resecting.
Yeah, I really believe that we don't have just one way to do things.
True.
We have to know different ways to do things because after you can make the planning and you also ultrasound, the CT, wherever. But when you open and see with your own eyes, you can see the best technique for that case.
Absolutely.
But we have to have the plan.
Got to have a good plan. You got to have a backup plan. And so my technique for dressing that gland is, once I've lifted up that platysma muscle, I'm looking at that gland, and I'll feed a suture through the platysma muscle, come right over top of the gland, or the remnant of the gland. There's a couple of bones or pieces of cartilage and bone in your neck, and way up high there's a bone called the hyoid bone, and it has some really tough periosteum. And periosteum is tough material that exists and holds the bone.